Thank you. My name is David Elson, and I'm going to give a history of results from osteotomy surgery. I'm a knee surgeon working in Gateshead, which typically looks like this most days. I'd like to thank my collaborators from the centres in Carlisle, Cardiff and Hampshire. I've borrowed this slide from Roman Sale in Luxembourg, who's a leading osteotomist, soon to be president of the European Knee Society. To introduce this topic, we need to understand the context in which knee osteotomies are used. It shows a typical interventional progression following an injury or degenerative process of the knee. You'll notice that an osteotomy is the last option shown in the green repair phase box. The patient retains their native knee, and when we go beyond that point to any form of joint replacement, the knee has been surgically amputated with no option to return. As a trainee, I worked for several knee surgeons who would routinely tell patients that despite their arthritic and painful symptoms, they were too young for a knee replacement. Subsequently, they were told that there was no surgical option. Go home and take painkillers until you're over the age of 60. So this is the key message from my talk. The time has come for younger British patients to question if their surgeon would consider performing an osteotomy rather than a knee replacement. If the surgeon doesn't have the expertise, then the patient should be asking for the opinion of someone who does. For the remainder of this talk, I plan to speak about the results of this surgery, starting from a historical perspective and moving on to the current data from our cohort studies, which gives us a real idea of what we can achieve with an osteotomy today. I'll briefly mention the National Registry UCOR, which we launched in 2014. In the historical era, before 1940, osteotomy was used to treat hideous deformities. William McEwen was a Glasgow surgeon who was able to apply the antiseptic principles which he had learned as Lister's dresser in order to become the world's first high-volume knee osteotomy surgeon. He was tackling the crippling deformities seen with rickets and tuberculosis. And in his 1880 book, he described his experience from 330 patients. Now, he followed up 14% of these patients at an unstated time period. And whilst this follow-up rate would be unacceptable today, in that century it was amazing to have any results at all. He stated that these patients were able to stand and walk with a greatly enhanced appearance. They were able to return to the following occupations. He was able to measure his success with walking distances, which I think also says something about how outcome scoring has evolved in the last 135 years. In the modern early years, lateral closing wedge osteotomies were applied for treatment of knee arthritis, but the techniques were still crude, with plaster casting or these flimsy staple fixation devices. Many surgeons in the UK still perceive that osteotomy is performed in this way with these crude techniques, but history has moved on. And so the results were okay, but not reliable or reproducible. For example, Harris in 1970 with only 72% good results. Insor in 1974 with 65% satisfactory, but 35% unsatisfactory results. In addition, complications included fractures, non-unions and nerve palsies. So when knee replacement was introduced to Britain in the 1980s, osteotomy failed to compete, but it remained in common practice on the continent. And a decade ago, Neil Thomas and Adrian Wilson visited Europe to learn about improving osteotomy techniques, and here they are in this photograph beside Ronald van Heerwaarden, who's considered to be a key authority in knee osteotomy. On their return to the UK, they established a successful osteotomy masterclass and the first local database. Their prize-winning commentary defines the new era of osteotomy surgery, which has evolved since the turn of the millennium. Medial opening wedge has become the predominant operation, and this has been enabled by the work of the AO Knee Expert Group, who adopted trauma plating technology to produce the Tomafix plate. And this really is a brand new way of performing osteotomy with a highly sophisticated approach in terms of planning and execution. Many of these leading surgeons attend the UK masterclasses as international faculty. We're getting better at selecting correctly, because there's an obvious role in younger symptomatic patients with deformity and partial thickness disease. In addition, osteotomy is now being used to unload patients with cruciate ligament injuries or restorative cartilage procedures. Our indications are constantly expanding to now include young, active patients who are displaying the signs and symptoms of early arthritis, who've perhaps had part of their shock-absorbing meniscal cartilage removed in the past. And that's why, in Germany, 20,000 of these operations are performed every year. Yet in the UK and the US, where this operation is not really well known, we're only doing slightly more than 1,000. Preoperative planning is now mandatory, and this is done with specialised x-rays of the whole leg and computer software for this specific operation. So we've moved into an era where patients will receive a personalised correction for their individual problem. We can rely upon the calculated opening distances during surgery, so live x-ray methods to confirm alignment are becoming historical, and this is leading to greater surgical accuracy. The plate is solid enough to reliably support opening wedges, which means that patients can put their full body weight through it, which facilitates earlier rehabilitation. And recent developments include smaller incisions, less invasive approaches, and infiltration of a cocktail of local anaesthetics into the soft tissues in order to minimise patient discomfort. And this is now an operation which can be performed in 45 minutes to an hour by an expert surgeon. The variable survival which we find in the literature is based upon the follow-up from the outdated closing wedge technique. And the results were poor because this was a fairly basic surgery where patients may have had no fixation device, or they may have spent weeks in a plaster cast recovering. Today there's no plaster, no brace, and crutches only if they're needed. The fixation devices are strong enough to allow early weight bearing and accelerated rehabilitation. It's only recently that we have the results from the opening wedge technique, such as the improvement shown in this sample of 78 knees. And this multi-centre retrospective analysis of a larger opening wedge group with favourable results. But we've recognised that clearly there's a requirement for an up-to-date UK evidence which analyses the results of the modern opening wedge. So this story starts with my developing interest in osteotomy surgery as a senior trainee in Newcastle. In order to gain some real experience, I spent 6 months driving across the country daily in order to work for Matt Dawson in Cumbria. Now, Matt taught me many things as I started out on my osteotomy learning curve, but perhaps the most important lesson was precision, and together we published on this topic. My favourite quote from Matt: "The treatment gap is a treatment opportunity." It was the end of my registrar training, and to facilitate my fellowship manoeuvres, I relocated to Staffordshire to be near my in-laws for childcare. Through his connections as an osteotomy masterclass faculty member, Matt helped me to arrange Mr. Wilson fellowships in Cardiff and subsequently Hampshire, which I commuted to on a weekly basis. Now, Chris Wilson in Cardiff is a real believer in the osteotomy effect, where patients receive benefit even from the slightest unloading of their degenerative joint surfaces. He stretched the indications for osteotomy, and we wrote up this case report where a femoral osteotomy was used to treat recurrent knee swelling. Chris has also been working with researchers from Cardiff University, supported by Arthritis Research UK, exploring the biological effects of osteotomy. Adrian Wilson has performed more osteotomies than any other surgeon in the UK. He's optimistic about the future impact that this operation will have on the way we perform knee surgery, stating osteotomy is going to be massive. Now, Mike Risbury is a highly skillful surgeon who also works in the Hampshire region, and he describes osteotomy as an amazing operation. During my time in Hampshire, the work which we started with UCOR was reaching the end of development, and so we were able to publish this commentary in the knee, laying out the stall for our national registry. So working in these high-volume centres has given me access to these different databases, which I was able to modify and combine into this table, which is much larger with 693 knees, 547 tibial osteotomies, and 108 on the femoral side. So I'll present the tibial osteotomies first. 528 were medial opening wedges, which, as you can see, is the most commonly used operation. Of these, 51 cases were bilateral, so the sample was 477 patients, the majority of whom are men in their 5th decade who've narrowly avoided being categorised as obese. Kelligan-Lawrence is a scale which we use to describe the severity of arthritis, where 1 being very little arthritis and 4 being bare bone arthritis. And this grades increase as the arthritis gets worse. The majority of patients in our cohort were graded as 2 or 3 for arthritis severity. The Tomofix plate was the most commonly used device. So the osteotomy was performed, and we've been gathering our outcome scores using the typical scores which we would collect for these kind of patients. Perhaps the most important being the Oxford knee score, which then can be compared with research on knee replacements. Now, this is ongoing work, and at the last analysis we had scores on 418 patients, which is 79% of the sample. We're now employing staff with the aim of achieving 90% follow-up. I'll show this slide to demonstrate that more than half of the operations were performed in the last 4 years, which goes some way to explain our similar follow-up curve with an average follow-up at 2.8 years. Tibial osteotomy resulted in clinical improvement, with Oxford knee and Coues scores increasing by 11 and 23 points. A visual analogue scale for pain reduced by 33 points. 87% of patients thought that their osteotomy was at least good, if not very good or excellent. And 87% would undergo the surgery again. So let's put that in context. The 87% of satisfied knee osteotomy patients is greater than the 82% of satisfied knee replacement patients in this large survey conducted by one of my contemporaries, Paul Baker. And let's not forget that osteotomy patients tend to be younger and more active with higher expectations. So in the opinion of patients, 90% felt that they were made better. And when asked, the average satisfaction was 8.2 out of 10. So the great news is that very few of our patients have had to have their operation revised or changed to a knee replacement, which we would consider as a failure. These were the observed complications. So apart from one perineal nerve palsy, we haven't seen any of the dreaded neurovascular complications that used to be associated with osteotomy in the past. And I think this is due to diligent protection of the structures at the back of the knee. So in summary, these are the successful outcomes of a UK multi-centre cohort of medial opening wedge, high tibial osteotomies. The majority do well from this surgery with the improvements that are shown in this slide. I'm going to move on to speak about osteotomies which were performed above the knee on the femoral side. This is a study of distal femoral osteotomies which was performed in Coventry, and it's used 6 case series, the largest of which has 40 patients. When quoted, the Hospital for Special Surgery score demonstrated improvement, and decade survival ranged from 64 to 87%. In our database, we include 108 distal femoral osteotomies, which is larger than any case series in the literature. The majority were medial closing wedges, but there are some other wedges which were planned on an individual case basis. With 4 cases on both sides, this was 104 patients, again the majority of whom are males in their 5th decade. Mostly grade 2 severity of arthritis, and again more than half of the operations were performed in the last 4 years, which explains our follow-up curve at 2.3 years. Now we had access to scores on 87 patients, which is 81% of the sample. Femoral osteotomy resulted in clinical improvement, with Oxford knee and Coues scores increasing by 11 and 25 points. The visual analogue scale for pain reducing by 34 points. Interestingly, these improvements are just slightly better but very similar to the tibial osteotomies. The average satisfaction for femoral osteotomy was 8 out of 10. And again, we only had 1 case which was converted to a knee replacement, which is an outstanding success given the amount of patients we were operating on. We had complications in 10% of this group, which is considerably lower than the rate of historical complications. So to summarise, these are the successful outcomes of a UK multi-centre cohort of femoral osteotomies. So I'm going to move on to speak about the United Kingdom Knee Osteotomy Registry. We use the abbreviation UCOR with the tagline, Improving Patient Outcomes in Knee Osteotomy. And really this is an initiative which we set up in order to gather data for osteotomies in the future. It was an idea suggested by Neil Thomas many years ago, but at a practical level this project has been gaining momentum for the last 2 years. And it's a natural progression from the work that I've just presented previously. It became obvious that a national registry would be a far more sustainable way to gather future data and allow many different centres to collaborate towards a common goal. Now, when I first spoke about this project, we defined these simple short-term goals, which I'm very pleased to say have now all been satisfied. As a BOA Transitional Fellow in Cardiff, we were asked to submit improvement projects to the British Orthopaedic Association, and I was fortunate enough to be able to place this work under the umbrella of that. And the poster here was submitted at the Brighton conference. It's currently displayed on the stand outside, and it explains the processes and timeline which was necessary in order to establish a national registry, which, as you might imagine, isn't necessarily straightforward. And at times I surprised myself by what we were able to achieve. I think a key factor for me in this process has been the support of the steering committee, comprised of the faculty members of the osteotomy masterclasses. And this has been essential for strategic decision-making and credibility. The British Association of Knee Surgeons have been very supportive, accrediting our activities, as well as giving us a recurring grant. And the British Orthopaedic Association hold an account for our transactions and are offering practical support to all the fledgling registries through the newly formed Quality Outcomes Committee, where I hold a seat as registry lead. We're very grateful for our industry sponsors, and now we deliberately approach several different companies in order to reduce our bias towards any one particular allegiance. And this has provided us also with some financial stability. UCOR has progressed from a concept in 2013 through development in 2014 to a point where we went live for beta testing in September and officially launched last November. Since launching, we have 24 surgeons who are actively using the system, and at the last count, 418 patients. Now that's all happened in our first 6 months. We've worked hard to produce this informative and engaging website with information for both surgeons and patients. And the website has been visited by more than 5,000 people since it's been live in the last 6 months. We authored this editorial, which was published as the first article this year in the Knee Journal. The aims of the registry were outlined, with our focus on driving quality improvement through patient outcomes. Our specific goals at the outset were to define patient selection criteria with greater clarity, to identify the devices and surgical techniques which give the best results, and to use stratified outcome data to influence the choice of intended alignment correction. So what do we need from this audience and our patients to make UCOR a success? Well, we've done some market research, and we think that the majority of surgeons would be willing to engage with a national registry for osteotomies. This is the proposed schedule of forms, and for a surgeon, this is a radiographic assessment before and after the operation, and obviously there's a form for the osteotomy where they record details at that time. Now, I can't say for certain what's going to happen in the future, but we've proposed a schedule for the next 30 years so that we can gather data over a prolonged period of time in order to really find out whether this is a successful surgery in the future. Patients complete scores online, and when they do so, those scores are collated by the system so that the scores are generated, and these can be plotted graphically. This is one of our first patients, and you can see on the graph very clearly that they've improved in their function. So now that we're in a promotional phase, it's worth being mindful of what we hope to achieve. Our midterm goals focus on the recruitment, and we're looking to engage both high and low volume osteotomy surgeons. So even if you only do very few osteotomies, we would still welcome your input. Now, we're thinking about how we can ensure good quality data and improve compliance, and to this aim, we've tried to make this process as easy and transparent as possible. We've made videos which speak to both surgeons and patients through the website and embedded as links in emails. In the long term, we aim to publish using UCOR data with messages designed to improve best practice by assimilation. We want recognition for all the surgeons who've taken their time to contribute to this process, and we've unanimously approved an inclusive publication policy, such that all manuscripts will be published and authored by the UCOR Research Collaborative. Final slide, I'm just going to mention the osteotomy masterclasses, which is an educational experience for surgeons who are interested in this kind of surgery. Now, these courses have been running for many years. The Basingstoke course is now in its 8th year. The Northern course, running in Newcastle, had its first year in 2015. And this is really a way for us to bring osteotomy to surgeons in the UK who are interested in finding out more about this surgery. It's an educational experience, and to quote one surgeon who attended the Northern course, he said it was one of the most enlightening educational experiences he'd had since leaving medical school. Thank you very much for your attention. Thank you for that question. Yeah, absolutely. What does this all mean for the patient? Well, I think really patients have now got more options available to them. If we go back to the slide I presented about being told that you're really too young for a knee replacement, well, the fact is that just isn't true anymore, that there are surgeons in this country who may be able to provide you with a surgical option to treat your pain, so that you're moving away from an era where you just had to tolerate your pain and just take painkillers in order to mitigate your symptoms. And now I think it's important for patients to understand that they really, as consumers, ought to be shopping around and looking for surgeons who can give them a viable option in order to take away their pain and improve their quality of life. Yeah, thank you for that question about weight bearing. You're absolutely right. Essentially, the reason we can do that is because the plates are now strong enough and stable enough in order to actually hold the bone so that the bone doesn't move even when patients put their weight through it. And the reason that happens is that the plates are very strong. They've taken the technology from the trauma plating, and there's a sufficient amount of screws in order to actually really structurally hold the plate absolutely rigid so that patients can get moving almost immediately after their operation.